My name is Nicola Seno. I'm the lead for Health and Justice Commissioning Support at North of England Commissioning Support. I'm here on the HOPE programme, which is a European funded programme which explores different countries sharing expertise and hosting placements in your area of interest to share best practice knowledge and skills which you will take back to your country of origin. So I'm doing this month's placement in collaboration with WEFREN, the Worldwide Prison Health Research Engagement Network. I'm doing it in conjunction with NHS England, the Leadership Academy, and of course my organisation, North of England Commissioning Support. And this week's episode is going to look at what I've seen since then. So essentially, I've done numerous visits to numerous locations, which have really helped inform my findings. So the first place I visited was the Hospital de Alarcón in Madrid. I also met with the Ministerio de Justicia for Catalunya, which is the Catalonian Ministry of Justice, and I met with Elizabeth Turo Santigosa, the Director of Offender Healthcare for Catalonia, and Carlos Soler, Rehabilitation and Health Programmes in Prisons in Catalonia. Here's a photo of me with Elizabeth. Also spent around 10 days at an absolutely amazing hospital called El Hospital Clínic in Barcelona, which is widely regarded as one of the highest performing hospitals in Spain. It's usually ranked either 1 or 2 in terms of national performance, and lots of lessons which we can embed in offender healthcare have come out of that 10 days experience. The focus of the blog today is going to be similar to last time. I'm going to look at what I've discovered around offender healthcare that's similar to the UK, similar challenges, what's different, what can we learn, and what's the role of the patient voice. There are lots of similarities actually, and a lot of the time I've spent has been in Catalonia and Madrid, and it seems that pathway development is a really key focus across different health systems, whether that be the offender healthcare system or the hospital kind of system, linking in with community settings. There's also very similar health needs and crime profiles of the patients that we work with within offender health, but interestingly there's some quite different demographics here, particularly in Catalonia. There's a younger cohort of prisoners. They don't seem to have the same ageing prisoner population that we have in the UK. There were a few reasons given for that around potentially they have a law which means that anyone with health issues over 75 is not allowed to be in prison. So straight away that older cohort of prisoners isn't there. But there's also a cultural issue around a lot of people feel it's inappropriate to send older people with health issues to prisons. There's a higher proportion of women in prison. We only have around 4% of the prison population in the UK. That seems to be a little bit higher here in Spain. And there's immigration as a demographics impacting on the health profile of patients here. There are some prisons in Catalonia, for example, that their population is around 60%. So what's similar? There are challenges around information sharing, clinical records on pathways. There's been extensive investments in this area in Spain, particularly in Catalonia. And in 2014 there was a huge investment in this area to mean that clinical records would match up with community settings and prisons. It seems that different health systems within Catalonia speak to each other and that clinical record is shared, which is fantastic. What's similar again is the feeling of transformation. So in the UK within offender healthcare there is a feeling that things are transforming, things are always developing and progressing. There's been lots of initiatives, there's new service specifications coming in around substance misuse, mental health, around mental health services for children and young people. We've got the 5-year forward view. This transformation agenda is huge, particularly in these high-performing hospitals in the community, such as a hospital clinic. But I think the interesting difference is that they don't always feel financially driven here in terms of making financial savings and financial benefits. And there seems to be a real can-do attitude in this culture of change and a real strong leadership from the top, with huge buy-in from stakeholders. And what's interesting is that a lot of the transformation projects within offender healthcare and within these big hospitals that I've been witnessing have been driven by the clinicians, which again is fairly different. We have a lot of initiatives within offender healthcare in the UK that are led obviously by project managers, program managers, but actually what I'm seeing here is that there's always a key kind of doctor, clinician, psychologist, psychiatrist leading a project. What else is similar? So within offender healthcare and also within the hospital settings here in Catalonia, infrastructure is a massive challenge within healthcare settings, and it's really interesting because huge investments have gone into delivering healthcare services in old historical buildings that are not fit for purpose. This is a massive challenge that faces us within offender healthcare, having to deliver healthcare services in clinical settings in buildings that potentially are not fit for purpose, where huge investment is required. Those buildings often aren't owned by us in the NHS, but there seems to have been huge progress in this area in Spain, and massive investments in getting those buildings up to standard and up to spec. Another commonality that I've witnessed here is the huge prevalence rates around mental ill health among the offender healthcare population. And the lack of early intervention opportunities available for people with mental health issues who are at risk of entering the criminal justice system. They don't seem to have liaison and diversion services or opportunities here, and the pathways are very complex, and there isn't much availability for the police to encourage patients into pathways in the way that we have at home. So there's been a lot of feedback about there's a need for that in Spain. There's been in Catalonia a huge transformation around mental health services in prisons, similar to the UK with our new service specification and coming online, and the CYP approach that we're taking of the last few years around secure stairs, FCAMs. And there's been a huge investment ensuring that there's now in-house mental health facilities at all prisons, and that wasn't the case a couple of years ago, but the rise in prevalence rates has meant that they've had to adapt to that and implement something important. Okay, so what's different here in Spain compared to the UK? Well, regional resources seem to be really big here. And again, I talked about this last time around the autonomous communities having the autonomy to kind of buy things across a region rather than just locally. So within offender healthcare, they talk about being able to commission shared resources for the 9 prisons they have in Catalonia. So they have one central mental health secure facility, 65-bed unit, and one physical health inpatient unit providing intensive rehabilitation, again a 75-bed unit. These are on site within prisons. They also have one specific commissioned secure area of a central hospital dedicated to patients from an offender healthcare kind of situation from prisons who need specialist intervention. The feedback was this system works really well and meets patient demand fantastically with really good outcomes and a high quality of care. And this goes back to the research that Mark Britnell did around payer power. You've got one pot of money across a region which is commissioned shared services for offenders. And what we find in the UK, that the inpatient facilities and kind of shared resources and access to mental health secure beds can look quite different from region to region. Another thing of note is that there's been a huge focus on resettlement of prisoners with health issues here in Catalonia. There's some legislation to support this drive, and I know there's been a lot of work on Through the Gate and in this area in the UK with the creation of CRCs, but evidence is still not there to say whether that's really working, particularly the links with a health perspective. However, here there's actual legislation to say that prisoners must see a GP within 15 days of release, and they have this specialist resettlement nurse role in all prisons for all prisoners. She attends, or he, all resettlement planning meetings to facilitate access to continuity of care in the community for that patient if there are any health needs. Again, this model of resettlement nurses and ensuring healthcare attend all those resettlement meetings is something that's been talked about extensively. Things look different from region to region. Some areas that's really embedded, others it isn't. But what that means is kind of lack of equality for one patient who might access services in one prison versus another. There's also another role which I was really impressed by, which is a buddy role for patients with mental health issues leaving prison. So community mental health services buddy up with someone due to leave within 3 months, and they do a lot of the hand holding. So prior to release, there'll be an advocate for that person, and they'll take them out on Rottle into the community to introduce them to their new workers in the community, to their GP, to ensure medication, again, continuity of care. And again, the feedback around that role was absolutely fantastic. So high prevalence rates around mental ill health were evident, and they've really responded to that with some quite dynamic ways of working. Again, another thing of learning that I've discovered is around technology. Telemedicine is huge here. It's absolutely enormous. It's completely embedded, and it's just business as usual for the offender healthcare population. So the hospital in Madrid, Alarcón, which I visited, has got a specialist telemedicine suite in the basement, directly linked to prisons for daily consultations across just lots of different specialisms, and that list of specialisms is growing. It's accepted by the prison as daily life, and they facilitate those sessions on the prison side. It's expected by clinicians as daily life. Again, no issues whatsoever. And it really integrates the care and encourages those relationships. And again, the feedback's been absolutely fantastic. And I know telemedicine's had a clunky start. Again, there are some areas that are using it really successfully in some prisons, others that aren't, but it's not fully embedded and business as usual in the UK. So I wanted to touch on the use of kind of management consulting techniques such as lean methodology, Kaizen and continuous improvement tools. This seems to be absolutely massive in Spain, and spending some time at El Hospital Clinic in Barcelona, the high performing hospital, they're using these tools to review clinic utilisation, patient pathways, and I think these are tools that we should be using more in health and justice. I think there's so many opportunities for us to review pathways, to review line routes and access to clinics running in prisons, actually observing the patient journey. And I think there are so many opportunities. And again, this is business as usual in Spain. Using these kind of methodologies seems to be day-to-day life, and I think we need to think about that more. So finally, on to the role of patient experience and the patient voice. So it's really interesting because I'm seeing a really active patient model within the offender healthcare setting. So telemedicine links with prisons is really kind of moving away from this paternalistic approach of clinicians telling offenders this is what you should do, and the sessions that I observed were very participative, and there was a really active patient voice in the process of consultation. And I think it's very difficult for patients in a prison setting to feel empowered about their own care because they often don't have that control around their environment, their food, their exercise. But encouraging this telemedicine and this collaborative approach between the clinician and the patient in a prison setting, it did seem to start to encourage that active patient role. And that was also confirmed by the Ministerio de Justicia in Catalonia, that's the direction of travel they want to go towards. Also, around patient experience, there are so many transformation projects here that I've seen over the last week or so, particularly at El Hospital Clinic in Barcelona, that are all around enhancing the patient pathway and experience. So they're getting feedback from patient surveys, focus groups, but they're also doing patient tracking. So they're actually monitoring kind of visually the journey of a patient through healthcare services. Really important work for them here in Spain. And again, I think there's so much we can learn from that from an offender healthcare perspective. Can we observe patients, their experience more, and feed that back into the commissioning cycle? I think it's something, again, to focus on moving forward. So conclusions, again, massively interesting, really enjoyed my time here so far. Innovative work, transformation, lots of learning, lots of management tools, very similar health need and criminological need, but slightly different approaches. And I think a lot of that comes down to, as Mark Britnell says, payer power and the autonomy of the autonomous communities to put quite innovative solutions in place. So I'll be back in blog number 3 with some more learning. Anyone got any questions, you can contact me on Twitter or via email, and I look forward to seeing you next time. Thank you. Bye.